I'll start. So good afternoon everyone. Today I'll be discussing about corneal laceration repair. So to introduce, corneal lacerations and perforations represent 6.8 to 14.7% of ocular traumatic injuries. The place of injury may be household, workplace or others like blast injury. So about the Birmingham eye trauma terminology system, it broadly classifies eye injury into two types, that is open globe injury and closed globe injury. Open globe injury is an injury which involves a full thickness wound of the eye wall, that is the cornea and the sclera. So here we will be talking about corneal laceration, which is a full thickness wound of the eye wall by a sharp object, which can be further divided into intraocular foreign body, a penetrating injury which consists of an only entrance wound, and a perforating injury which consists of both entrance and exit wound. First things first, whenever we come across a patient with ocular trauma, we must assess the patient, counsel, prognosticate and timely refer if needed. Any life-threatening injury must take precedence over ocular trauma. The vision at the time of presentation and presence or absence of afferent pupillary defect are important prognostic factors in the ocular trauma classification system that has been mentioned here. So before we take up a patient with any surgical plan, we must do a comprehensive workup, which includes assessing all ocular structures like the conjunctiva. We should look for any chemosis, hemorrhage, any foreign body. The subconjunctival space should be assessed for again foreign body, any phacoceal, any prolapse vitreous. Similarly, there may be an epithelial defect, any epithelial flaps, foreign body laceration or any tissue loss in the cornea. Similarly, sclera, the anterior chamber, iris, lens and posterior segment must be evaluated in detail. So what are the goals of management when we come across a patient with ocular trauma? Firstly, we want to ensure a watertight globe and maintain the globe integrity and normal intraocular pressures. To remove any contaminated and non-viable tissue and any foreign body if present. Also to deposit any viable tissue to restore the original anatomy and avoid iatrogenic damage and restore visual function if possible. So now coming to corneal lacerations, they can again be divided into partial thickness lacerations or full thickness lacerations. So we must examine carefully to rule out any rupture of Descemet's membrane. If any doubt, Siedel's and precious Siedel's test should be performed to look for the thickness of the laceration. So now coming to full thickness lacerations, a simple laceration is a laceration involving the cornea, sparing the limbus and no uveal tissue incarceration, which can be managed simply by corneal sutures. If there is associated uveal incarceration, we have to take a decision about repositioning or abscission of the uveal tissue. If there is lens involvement, lensectomy may be required. For concurrent vitreous involvement, vitrectomy may be required. For scleral involvement, it has to be managed with scleral sutures. And if there is any tissue loss, a patch graft or a penetrating keratoplasty may need to be done. Now coming to the choice of anesthesia, most of the cases of ocular trauma are managed under general anesthesia, which gives a dual benefit of excellent anesthesia and akinesia, and there is minimal increase in intraocular or intraorbital pressure. However, topical and local anesthesia may be suitable for cases with small anterior defects. Now coming to ocular triage, we have to give first preference to the globe. Repair of any adnexal injury should follow the repair of the globe, as eyelid surgery can put pressure on an open globe. Now we would like to discuss about suturing. So what is an optimal suture? An optimal suture is a suture which makes the wound watertight, minimizes postoperative edema, minimizes scar formation, minimizes interference with the corneal curvature, and minimizes any late complications such as synechiae, glaucoma, etc. Now, when we suture a corneal perforation, the first and foremost is to identify the anatomical landmarks, and we aim to preserve the anatomy as much as possible. Thus, we have to secure the landmarks first, especially the limbus, in order to save the anatomy. Now, the type and technique of suturing. So, for corneal sutures, we use 10-0 monofilament nylon on a fine spatulated microsurgical needle. The intended depth of sutures is 90 to 95% through the stroma. We avoid going full thickness in the cornea because it can act as a conduit for bacterial infection and thus lead to endophthalmitis. The ideal suture length is 1.5 to 2 millimeters and an equal depth on each side should be there. We follow a simple rule of progressively halving the wound with simple interrupted sutures. So for suturing, we have to use 3 throws. The first throw we tighten perpendicular to the wound. The second throw is tightening parallel to the wound, and the third throw is again perpendicular to the wound. So for corneal sutures, we perform the no-touch technique, wherein we do not touch the lips of the wound and directly insert the needle. This prevents any further edema or maceration of the wound lips, which can lead to further damage. So now this is the rule which we follow for vertical lacerations. The entry and exit points should be equidistant from the laceration, as we can see in the image A, where the entry and exit points are similar, which leads to a proper wound apposition. However, the image B represents that the distance A is less than B, which leads to further overriding of tissue. However, this rule does not hold true for shelved lacerations or oblique lacerations, where the entry and exit points of the suture on the posterior surface should be equidistant. So here in the image D depicts the correct technique of suturing, where we see that C is equal to D, that is on the posterior surface, the distance from the cornea is equal. However, on the anterior surface, it is different. Whereas this image C, if we see the anterior distance is equal, then it leads to overriding of tissues. Now coming to how many sutures, to understand the number of sutures, we have to understand the concept of compression zones. So each suture has a compression zone, which is a roughly triangular configuration extending approximately 1/2 of the total suture length in either direction along the wound. So here the image B represents the ideal suture distance, which is equal to the length of the suture, so that the compression zones just overlap or are in contact. If there is excessive overlap or no overlap, then it will lead to astigmatism. Now, Rossi-Hayes technique is a technique which aids in preserving the normal spherical contour of the central cornea, wherein the central cornea is steep and the peripheral cornea is relatively flat. For this, we aim at providing small, short central bites in the central cornea and long, tight peripheral bites, which helps in maintaining the contour of the cornea, which can be done for limbus to limbus corneal lacerations. Now, coming to the management of angular corneal wounds, the initial suture should be placed in the angle of the laceration, and the further sutures are sutured from the angle and not towards. For complex angular wounds, similar rule is followed at all angulations. So we treat a complex wound as multiple separate lacerations and the central part is closed last. So herein, this is a complex laceration where the first we close the angles, that is 1 and 2, and then it divides into 3 separate lacerations. The peripheral lacerations are closed first and the central laceration is closed last. So the numbers here denote the sequence of suturing. Now for management of triradiate or stellate corneal perforations, 2 techniques have been described. The Atkins method describes a purse string suture where the cornea is treated as multiple flap tiers and each flap is sutured to the other. The straight arms are first opposed and then the angulated tips are sutured. Eisner et al. Also gave another method of stellate perforation repair, wherein we create partial thickness grooves between the grooves of the laceration using a diamond knife, and the needle is introduced through the grooves to create a purse string effect. Now, just briefly about corneoscleral laceration repair technique. So firstly, we should do a 360-degree peritomy and Tenon's capsule is retracted posteriorly so as to get a good exposure of the sclera. The scleral wounds are closed from anterior to posterior using a close as you go technique. Any disinsertion or reinsertion of recti may be done if required for proper exposure. Interrupted sutures are passed through the deep sclera using 6-0 vicryl, which is an absorbable suture. For sclera, the intended suture depth is 80%. And forceps use is mandatory to securely grasp the resistant sclera, as unlike the cornea. So this is a pictorial representation of a case with a corneoscleral perforation. So here in the first image at the beginning of surgery, we can see that there is a linear corneal laceration extending into the sclera and associated uveal tissue prolapse. So now the first stage in this process will be to clear the debris, any vitreous and uveal tissue, and first suture has to be placed at the limbus. That is the anatomical landmark. So here we have placed a 10-0 monofilament nylon at the limbus. Following the anatomical repair of the limbus, the second is the placement of the corneal sutures. In this case, again, the Rossi-Hayes technique was performed and corneal sutures were completed. And lastly, the scleral component is repaired using 6-0 vicryl, and at the end of the surgery, the peritomy is closed and we see that the anterior chamber is formed with a mobile air bubble. So we must remember the golden rule, that is LCS. This is the sequence of suturing. First would be the limbus, followed by cornea and then the sclera. Now coming to prolapsed iris, to take a decision whether to reposit or not to reposit, we must preserve the uveal tissue as much as possible. There is no magical period of iris reposition. However, 24 to 36 hours is considered the maximal safe period for iris reposition. In apparently or visibly infective corneal lacerations, we should never reposit the iris. If prolapsed iris is necrotic, do not reposit. Abscission of the excess necrotic tissue and not excision should be done. Also about management of lens matter, there are few indications for doing a lens aspiration in primary sitting for a patient with ocular trauma, namely any disrupted anterior capsule with flocculent cortical material into the anterior chamber, cases in which there is vitreous involvement, and cases where the lens is cataractous and surgical visualization is good, which is based on the surgeon's preference. However, in most other cases, elective cataract surgery is planned as a second stage procedure, which gives us a more controlled environment. Also, for the management of corneal perforations with associated tissue loss, there are various methods of wound closure. The most preferred one is the fibrin glue or cyanoacrylate glue along with a bandage contact lens. In other cases, amniotic membrane transplantation or a Gunderson's flap can also be done. In cases where there is availability of donor cornea, a patch graft or a penetrating keratoplasty can be done based on the extent of the perforation tissue loss. So now coming to the surgical video. So this is a case with a corneal perforation and uveal tissue prolapse. So let's see the video. So firstly, we have to make 2 side port entries using an MVR blade. Care must be taken not to damage the iris tissue, as the anterior chamber is shallow in most of these cases. So the membrane over the prolapsed iris tissue is gently peeled off. This patient presented within 24 hours of injury and the visible tissue was not necrotic and seemed healthy. So it is gently reposited back into the anterior chamber using an iris repositor. Viscoelastic can also be used at this stage to help in the repositioning of the iris tissue. So after repositioning of the iris tissue into the anterior chamber, we note the extent of the corneal perforation. Also in this case, we can see that there is an associated hyphema. The lens is cataractous, but it will be dealt at a later stage. So please note the no-touch technique that is being employed here for the corneal suture placement, where we do not touch the lip of the wound, and counter traction is gently applied using the other forceps. So the first knot will be tightened perpendicular to the wound as discussed. We should ensure that the suture is neither too tight nor too loose. A loose suture will lead to wound gape, and too tight a suture will result in astigmatism and corneal flattening. The second knot is again tied parallel to the wound, and similarly the third knot will be tied. The remaining corneal sutures are placed following the 50-50 rule, where we divide the wound into 2 and then further progress. Final sutures are being placed in the cornea. The anterior chamber is formed using air bubble. Here we can see that the air is releasing from the wound, so certain sutures need to be replaced. The knots have to be buried within the cornea, because the knots, if they are exposed, it will lead to ocular surface irritation. We prefer to bury the knots away from the visual axis. Finally, we have to take care that no iris tissue is adherent to the wound, which can be checked using an iris spatula or a blunt cannula. At the end of the surgery, we want a formed anterior chamber and a watertight globe and no leak of air. So coming to the post-operative management of a case with ocular trauma, patching or shielding depends on the wound characteristics, patient compliance and patient preference. Topical steroids are a must in any case of ocular trauma to control the inflammation that is ongoing. Antibiotics to prevent any secondary infections. Cycloplegics are used to alleviate the pain that is associated with the ciliary spasm. Suture removal has to be done in a timely manner, usually conducted at 6 to 8 weeks of the primary repair. Thank you.
Thank you, Siddhi. You have covered the points well. Would you like to recapitulate just the basics of corneal perforation repair 1, 2, 3, 4?
Thank you, ma'am. So yes, definitely for corneal perforation repair. Yeah. So for corneal perforation repair, the first thing is that we are performing the no-touch technique. So since we are using spatulated needles, there is no need the needle goes through the cornea very easily. So we want to prevent any further damage to the wound edges, which can lead to further edema. Also, that the length of the suture bite should be equal on both sides. However, if there is excessive edema in the cornea, then we may have to increase the length of the suture so that the edematous tissue is not covered, as it can lead to cheese wiring of the sutures. Also, about the different management of vertical as well as oblique lacerations, the different rules apply. And at the end, we have to have a formed anterior chamber and a mobile air bubble. And in case of pediatric cases, we must also suture all the side port entries. And a thorough post-operative care and management is a must.
Yes, Siddhi, very well recapitulated. There are a few questions, I think, by Toshit. I'll just try to read them. Yeah. What can be done when the cornea is edematous to an extent such that there is cheese wiring of suture? In such cases, in the peripheral cornea, we try to take bigger length suture. Should the same thing be done when cheese wiring occurs in the central perf? So, Toshit, I think Siddhi has already answered this question, that you have to go beyond the region of corneal edema, even if it means a longer suture in the center. First goal is apposition, second is astigmatism, etc. control. Okay, so you have to go beyond the edematous cornea and take a longer bite, even if it is in a central corneal perforation. Second is, what should be the end point in a large corneal laceration, watertight wound or airtight wound? I think an airtight wound works well enough in these cases. And third is it advisable to give mydriatics in case of uveal tissue incarceration at the corneal wound site, which could help in deposition of iris tissue? Uveal tissue incarceration should not be there at the end of perforation. Mediatics we do give in any case, but you have to release the incarcerated uveal tissue throughout surgery, during the surgery. And Ayush has asked, is there any indication for oral steroids post-operatively? So Siddhi, can you tell about our usual regimen?
It depends on the case to case. So if there is excessive inflammation based on the initial presentation or the extent of injury, we usually prefer to give oral steroids in the post-operative period, but a short course of steroids is given. And on subsequent follow-up, we can taper accordingly.
Yes. And second is, can a trial of topical antibiotics be given if surgery is delayed? And if yes, what is the time cutoff when it should be started? Siddhi?
Okay, so basically, if the patient presents with an open globe injury, we always try to avoid topical antibiotics. So in that case, when we suspect infection, we start oral antibiotics in that case. And once the globe has been restored, we can start topical antibiotics.
The aim, Venkatesh, should be to repair as soon as possible. Topical antibiotics is not going to take care of the primary pathology. And the next question by Sohini is interrelated. If there is a increased interval, you can even go for intravitreal antibiotics during perf repair if it's delayed too much. So Sohini has asked Siddhi, that is prophylactic intravitreal antibiotics recommended in all cases of perforation? So, and what are the indications of intravitreal antibiotics? This is why we need.
I had discussed that firstly, we should assess the entire case, and for all patients, posterior segment evaluation is a must. So if we can assess the fundus clinically, it is good, or ultrasound should be done. And if there is any vitreous exudation, or if we are suspecting any infective case, definitely intravitreals have to be given. But a patient, if he presents within 24 hours and presents with a clean wound, then prophylactic intravitreals are not recommended.
Okay, so one more question from my side. We recently had our Diwali post-Diwali heavy casualty. So in firecracker injuries, when would you consider intravitreal antibiotics, even if they are presenting early?
I think in firecracker injuries, we can be, because of the sulfur involved in the wound, there is more chance of infection. So we can go ahead with intravitreal in these cases.
I think the threshold should be lower in these cases because there is a higher risk of contamination from the barood, etc. that goes in and other stuff. And Mansi asks how to manage a case with scleral laceration extending beyond the equator.
Okay. So basically, again, for scleral laceration repair, we go from anterior to posterior. and we start repairing from the anterior end. Whatever is exposed, we first repair that, and then we can see beyond the equator. But if it is excessive, we do not go to an over repair, because it can lead to further damage. So as much as possible is repaired, but if it is beyond, close to the optic nerve head insertion, it is not advisable to repair. Anyways, the prognosis in such cases is very guarded.
Yes, correct, Siddhi. And we do sometimes hook the muscles and try to repair whatever we can see. But even some people have even said that they disinsert the muscles and then repair and then reinsert. However, I think however much you can see with manipulations is okay. Beyond that, we generally leave it. If it extends too
Can we
posteriorly.
stop sharing the
Yes, ma'am.
screen
The
share has to be
screen.
stopped, yes. And everybody,
Yes,
please,
yes, yes.
videos on. Videos on for everybody, including mine. Yes.
Yes, ma'am.
Videos on for everybody. Yes, yes, yes. And now keep asking your questions.
Yes. Next was in case of
Good. I can see
triradiate
so many
perf.
faces. Very good. Vishnu Todi, where are you? Akshara Pahuja, can't see you. Sai Vineet. Akshay Balaji is there today. Akshay Balaji.
Yes, ma'am.
Akshay Balaji.
Yes, ma'am.
You are there today?
Yes, ma'am.
Where did you disappear that day?
Ma'am, network issue, it got cut, ma'am, in the end.
Okay, anyway, now continue, please. Neha Sandhu, I don't see you. Reshma Kalathil, Vineet Kumar Batwani. Diksha, Srishti Sinha. Ayushi is, yes. Good, Diksha is also there. Srishti Sinha is not there. Okay, अब पूछो question answers.
Hanji. Next is in case of triradiate perforation, when should we consider glue and BCL?
So basically, for triradiate perforation, the ideal technique for management is a purse string suture. There are different techniques which have been described, but in case if you're not successful with the purse string suture or unable to get a proper apposition and there is a leak still, then we can go as a last resort using glue and BCL, which gives the proper control of the situation at that time.
Yes, and if there is a tissue defect, even despite your sutures, it's leaking, you can consider a glue and BCL. And Venkatesh is asking approach to scleral laceration behind the recti. I think we have already covered that. You can try hook the muscle and repair the perf. And some people have even described disinsertion of the recti, repair of the perf, and then reinsertion. So Vineet asks, scleral suturing should be full thickness or partial thickness? Siddhi?
So this I have already mentioned that in scleral sutures, intended depth is around 80%. We never aim for full thickness sutures.
Yes. And Priyadarshana asks how to ensure there is no vitreous in the wound. Should we stain with tricot?
Okay, so basically for vitreous, firstly we can, if you want to check at what plane, if there's a pupillary plane if you're looking, so a central round pupil should be there. But if the iris is damaged, you can check the anterior chamber by sweeping with a Sinski hook. If you're still not confident or sure about it, and also you have to use a cotton swab and check for the wound. If there is any vitreous, that vitreous tag will stand up and you can cut it with a Vanna scissors. If still there is any doubt, then tricot can be used to stain it, which will beautifully show the vitreous, if at all, if there is any.
Yes, often we do not require tricot staining because sweeping and the other maneuvers are enough. However, if there is any remaining doubt, you should definitely stain with tricot and assess. Now, Reshmi asks how to manage corneal wounds where edges are overlapping and adhered. Siddhi?
Okay, so basically, if overlapping edges, so we basically have to release any adherence. So gentle dissection using any blunt instrument or a visco cannula can be done. First, we have to restore the normal anatomy, that is the aim, and then after you have delineated the anatomy and the direction of the perforation, it can be managed.
Yes, Reshmi, I'm assuming that you mean that edges are overlapping and adhered, that there has been some time since the perforation, and that is why it's sort of a self-sealing process has started. So if you are going ahead with repairing, the AC is not formed, then you have to slightly freshen the margins, remove the fibrous tissue that has grown on that, and then suture them. You'll have to restore the normal anatomy as far as possible. Diksha asked, vegetative matter injury, early presentation, clean wound. Should we give intravitreal or intracameral antibiotics? Siddhi?
Okay, so again, this is a gray zone. So it is based on surgeon preference. But an early presentation, if you, a preventive approach can be to give at least intracameral antibiotics. And if you have any vitreous involvement, which we will assess preoperatively, then intravitreal can be given.
Yes, and vegetative matter, then again, you have to see if it's involving the posterior segment or a clean corneal laceration with lens and everything intact. Then you can take a decision that should you give intravitreal or not. Otherwise, immediately presenting with only a corneal laceration, you can go with a local irrigation of the wound only. Maybe you will avoid intravitreal. Ma'am, in certain firecracker injury, when entire cornea is tattooed with small particles after unsuccessful epithelial debridement due to deeper embedding, after how many days can we consider topical steroids? Siddhi.
Just a minute, I'll need to reread his question.
Okay, so firecracker injury, we get those particles because of that barut particles in the corneal stroma. So he's saying, which you cannot remove even after epithelial debridement because they go deeper, the gunpowder residue. So after how many days can we consider topical steroids?
I think we can start steroids in such cases, but a close follow-up is a must because inflammation has to be counteracted with steroids in such cases.
We do start intensive steroids immediately in the post-op period, Nipun. Ragini asks, ma'am, in densely adherent iris tissue and pigments to perforation margins, what is to be done?
Okay, so basically,
Siddhi.
densely adherent iris tissue, we have to, by gentle maneuvers, again using blunt instruments and using viscodissection, the iris tissue can be released. And if it is densely adherent if it is densely adherent, it must be an old prolapse. So then for that case, we have to abscise the iris tissue. And as far as pigments are concerned, pigments, as we cannot do an over, so whatever pigments are remaining have to be left, but there should be no adherent uveal tissue at the perforation margin for sure.
Okay, Ayushi asks, should we still give intravitreal antibiotics if we are not able to do an ultrasound preoperatively? Then we can do it intraoperatively, ultrasound, before starting surgery if the child is not cooperative or it's some such issue. But why have we not done an ultrasound? Any comments, Siddhi?
Now again, it's the same thing. I think the same questions is being repeated. So it's not just about the preoperative ultrasound, but we have to assess case by case. It is not a universal rule that applies for all perforations because it does not hold true for every case. So the time of presentation, if there is any active infection or not, and based on the glow, if we can see intraoperatively, we can decide.
There's a question on YouTube. Prithvi asks, any technique for reposition of iris tissues? I have had problem in reposition.
So there is no like a defined technique or a named technique, but basically, if there's any epithelial membrane or any adherent tissue, it should be released first. It should be gently peeled, and then using again iris repositor or viscodissection, a heel-on cannula works very well, where we can dissect the iris tissue from the margins of the wound and then gently reposit it back, as it was shown in the video also very nicely.
I think it's a very relevant topic. Siddhi, you have covered it well. I'm sure there must be many more questions because residents are repairing perforation. So even if beyond this class you have, please feel free to ask because this is a very significant surgery that we do day in and day out. And our half hour is up. I think we can move on with the next. I think a very comprehensive presentation, Siddhi.
Thank you so much. Thank you.
There are so many questions because I think the residents deal with the maximum emergencies, and so that is why
Yes,
they
ma'am.
need so many questions because they are our first contact in the casualty.
Yes, ma'am.
Either they are our first contact when they are first or second semesters, or they are our, I think most of the senior junior residents are also operating, isn't it?
Yes, ma'am.
How many of you have done repaired perforating injuries? You can just speak out, or you can show
Yes,
your.
ma'am. Yes, ma'am. The prepared injuries,
Okay.
most many corporations came in the last OT. We did firecracker injuries also. Large scalar and corporation.
Srishti is sitting at a place where others are also locked in. There's an echo. I think you're in the
OT changing room, ma'am.
OT changing room. Okay. All right, we'll move to the next presentation. Anirudh Kapoor has left the meeting. Please note. He left the meeting ना जो left side में आता है बहुत important है. चलो ठीक है अस्मिता.
Yes.
Start.
Good afternoon, everyone. I'll be discussing thyroid eye disease. I'll be mainly
Perceptor is there. Asmita, perceptor.
Yes, ma'am. Rachna ma'am has joined.
Okay. Okay.
I'll be discussing thyroid eye disease. I'll restrict my discussion to clinical course and management. Thyroid eye disease is an autoimmune disorder of the orbital retrovulvar tissues, commonly associated with a dysthyroid state. A systematic review was done and it was found that about 85% patients of TED had hyperthyroidism, about 10% had hypothyroidism, and about 7% were euthyroid. Conversely, approximately 25 to 50% patients of Graves' disease will develop thyroid eye disease, and sight-threatening disease is seen in about 5% of the patients. The course of TED can be divided into active phase and then burnt-out inflammatory phase. The first part is the self-limiting inflammatory active phase with rapidly worsening of symptoms, usually which subsides in about 2 years. After that, there is an inactive phase, which is a burnt-out phase with fibrosis and gradual improvement of inflammatory signs. However, it should be noted that the disease does not return to baseline, rather permanent fibrotic changes occur in the disease. The active phase is mainly caused due to TSH receptor antibodies as well as IGF-1 receptor antibodies and the inflammatory mediators like interleukin-6, which is the main inflammatory mediator responsible for the symptoms. The target cell is an orbital fibroblast which has the TSH receptors, which exhibits marked heterogeneity. It leads to differentiation of pre-adipocytes into adipocytes and increases the orbital fat. It leads to inflammation, which causes the orbital inflammation. It leads to production of glycosaminoglycans, which leads to enlargement of the extraocular muscles due to the accumulation of fluid. This is a diagram which is showing the thyroid stimulating antibodies as well as the IGF-1 receptor antibodies acting on the orbital fibroblast, leading to proliferation of the adipocytes along with an accumulation of glycosaminoglycans, leading to orbital tissue expansion. The lid signs which are mainly seen are the Dalrymple sign, the Von Graf sign, and the Cocker sign. The Cocker sign is mainly a staring and frightened appearance of the eyes. The Von Graf sign is a lid lag on down gaze, and Dalrymple sign is a lid retraction in the primary gaze, mainly due to fibrosis and contracture of the LPS muscle and increased sympathetic activity of the Muller's muscle. In these images, we can note the Dalrymple sign and the soft tissue changes in the thyroid eye disease. The retraction is often asymmetric, and the patients can show a staring gaze. This image is showing a Von Graf sign, and as we can see, there is a left upper eyelid retraction and lid lag on downward gaze. There are other name signs because of there is the fullness of the eyelids, the tremors of the eyelids, staring appearance, lid lag, lid retraction. These are further signs which can be memorized. Orbital signs include proptosis, which is usually bilateral and often asymmetrical due to orbital tissue proliferation as well as deposition of the glycosaminoglycans. The ocular motility restriction is there due to the inflammatory edema, and in the inactive phase due to the fibrosis of the muscles. The most commonly involved muscles are the inferior rectus, medial rectus, followed by superior rectus and lateral rectus. The muscles often increase to more than double their normal size. This leads to signs like an inability to converge eyes, which is called as the Mobius sign, as well as restriction of the movement of the extraocular muscles. CT scan has been done in such patients, and we have noted that some patients have an expansion of the orbital fat compartment, which is called as the lipogenic variety of orbitopathy, and some patients have an enlargement of the extraocular muscles, which is the myogenic variety of the orbitopathy, whereas some patients have both the involvement of the adipose tissue and the extraocular muscle tissue. This is important because this will guide our management when we are going to do an orbital decompression. This is an image showing the Mobius sign, which is basically an inability to converge. There is also a raised intraocular pressure in these patients. In the short term, it is seen because the eyeball is compressed by the enlarged and infiltrated extraocular muscles. In the long term, there is an increase in the episcleral venous pressure, leading to secondary intraorbital content and pressure increase. Differential IOP is a sign in which there is an increase in IOP in upgaze. When it is more than 6 millimeters, it becomes significant. Braille sign is an increase in IOP on attempted gaze towards the direction of limitation. Compressive optic neuropathy is seen mainly due to increased orbital pressure and also due to the mechanical stretching of the nerve due to severe proptosis. This is a classical image of an optic nerve edema with peripapillary hemorrhages, which is seen in thyroid eye disease, although it is seen in just about 5% of the patients. Risk factors are older age, smoking, male gender, and significant strabismus with mild proptosis. The rationale behind this is that when there is significant strabismus, there is involvement of the extraocular muscles. But if the patient has mild proptosis, there is very little space for the enlarged tissue. So that leads to compression as well as optic nerve involvement because there is very little space for the expanded tissue. So it will compress the optic nerve. Typically, visual acuity and color perception are slightly decreased and the RAPD is often questionable, and optic nerve might appear entirely normal on clinical examination. Defects are variable, paracentral, altitudinal, arcuate, or generalized constriction can be seen. Soft tissue signs are basically a congestion, a caruncular edema, periorbital fillness, etc. It is mainly due to the congestive nature and reflects that the venous drainage is being compromised due to compression of the orbital space. Gold-Zahir sign is significant in this where there is a deep injection of the temporal conjunctival vessels. This is an image showing the periorbital fullness as well as the chemosis and the conjunctival congestion. There are other signs like the Geoffroy sign, which is basically absent crease in the forehead on superior gaze, as we can see in the image attached. There are pupillary signs as well, which is the Coven sign, Loewe sign, and the Nice sign. Clinical evaluation is done by 3 different systems: the Werner's classification, the clinical activity score, and the International Thyroid Eye Disease classification, which is the VISA classification. Werner's classification will give us mainly the severity of the disease, and CAS classification and the VISA classification will give us the activity of the disease. So the Werner's classification, the first class 0 shows no signs and only symptoms. And in this, superior limbal keratoconjunctivitis has been recognized as a significant risk factor. In class 1, there are only signs. In class 2, there are just soft tissue signs. In class 3, there is proptosis. In class 4, extraocular myopathy. In class 5, corneal epithelial defects. And in class 6, there is a sight-threatening optic neuropathy. It should be noted that it grades only the clinical severity but does not distinguish between active inflammatory phase and the inactive phase. And indication for treatment is decided only on the basis of the severity of the disease. This classification was further upgraded by Werner himself in a paper in 1977. Only a few changes were made and the no-specs classification was, no-specs mnemonic was retained. The class 1 was changed to include about 22 mm of proptosis, and any proptosis in excess of 22 was put in class 3. And therefore, grading was also added because that was missing in the original classification, and grading was done from class 3 to class 6 for the various signs. But however, this was a strong limitation that it was not commenting on the activity of the disease, and we now know that the activity of the disease will help us decide whether or not we should treat the patient with immunosuppression. So clinical activity score was given based on the 4 of the 5 well-known signs of inflammation, which is pain, redness, swelling, and impaired function. 10 items are there and 1 point is given for each item. Total score is 0 to 10. Out of 10, if a patient has a score of 3 or higher or an increasing score on follow-up, the patient is judged to be active. These are the various signs which are included. There are 2 signs of pain, 2 of redness, 4 of swelling, and 2 of impaired function. This was further modified or amended by the European group on Graves' orbitopathy, in which they took 7 points for initial CAS scoring and 3 points for follow-up CAS scoring, and they said that in presentation, if the score is more than 3, then it is active, and in follow-up, if the score is more than 4, then it is considered active Graves' orbitopathy. Then there was a VISA classification which clustered the 4 functions which are disrupted by Graves' orbitopathy. It has a subjective input and has a reproducible objective input. It is not only a diagnostic classification, but also it helps in practical implications for guiding the management. This is a format of the VISA classification. It has a subjective component as well as an objective component, and at the bottom the grading is done. Because we treat optic neuropathy if it is present regardless of its severity, we only grade it as present or absent. Then we go for inflammation. Inflammation has 3 important components: chemosis, eyelid edema, and the pain score. Chemosis is graded as 1 if the conjunctiva is lying behind the gray line of the eyelid, and as 2 if it extends anterior to the gray line. eyelid edema is 1 if it is not causing any overhanging of the tissues, and 2 if it is causing a roll in the eyelid skin. The pain score is based on the patient's report of deep orbit discomfort, and an inflammatory score of more than equal to 5 is indicated of active disease. In appearance, there are symptoms like bulging of eyes, eyelid retraction, fat pockets, exposure complaints, etc. And in strabismus and motility, it is graded from 0 to 3 depending on how much is the restriction and how much is the diplopia. This sequence of sections is important because VISA reflects the order in which the problems should be managed. First, we have to look at the vision dysfunction, and if it is present, it is to be treated as a priority and treated with corticosteroids or radiotherapy. Then we look at the inflammatory signs, and in the last, we look for strabismus and appearance changes, and that is why the mnemonic has been given as VISA. On computer tomography, the most characteristic finding is normal tendon along with an enlarged muscle belly, and apical crowding is looked for to look for any signs of any presence of optic neuropathy. The Barrett's muscle index is basically a percentage of the orbit which is occupied by the muscles. A coronal scan is taken halfway between the posterior globe and the orbital apex, and it is used to calculate the index. The vertical index is the superior rectus plus LPS complex plus the inferior rectus divided by the orbital height, and the horizontal index is the medial rectus and lateral rectus thickness divided by the total orbital width. More than 67% indicates risk of optic neuropathy. On MRI, we see similar signs, the Coca-Cola bottle sign, because the bellies are enlarged and the tendons are spared. Inflammatory edema and activity leads to hyper-intense image on T2, and in fibrotic stage, it appears hypo-intense. On ultrasonography, we can see similar corollary findings as the CT scan and the MRI, and irregular internal structure is seen. The extraocular muscles have a lower internal reflectivity because of edema, and in the end stage, it shows a high reflectivity from the echogenic fibrotic scar. So if we have an eye muscle reflectivity of 40% or less, that will suggest an active thyroid eye disease. Management has been given by the European group on Graves' orbitopathy, mild, moderate, severe, and sight-threatening. In mild, we have just minor lid retraction, mild soft tissue involvement, and exophthalmos less than 3 millimeters. In moderate to severe, lid retraction is more than 2 millimeters, exophthalmos is more than 3 millimeters, and this is the stage which requires immunosuppression. Sight-threatening is mainly dysthyroid optic neuropathy and corneal breakdown. Mild Graves' orbitopathy has a minor impact on daily life, which is insufficient to justify immunosuppression. So we'll go for conservative management and watchful waiting. Basically, just stabilize the thyroid function, smoking cessation, head end elevation to decrease the edema, salt-restricted diet, topical lubricants, diplopia management with prisms, or oral antioxidant. Selenium can be given twice a day for 6 to 7 months. In moderate to severe Graves' orbitopathy, in the active phase, we will give steroids, immunosuppression, or orbital radiation. And in the inactive phase, we go for rehabilitative surgery only after the patient has been inactive for at least 6 months. In steroids, we go for high-dose steroids, prednisolone 60 to 100 milligrams per day. It has to be given for prolonged periods, and bisphosphonates should be given if it is being given for more than 3 months to counter the risk of osteoporosis. In a study done by Kahali et al., it was shown that even the TSH receptor antibody titers were decreased with steroid administration. Intravenous methylpred can be given. The regimens are as described in the inset box. It is given only after recent hepatitis, liver dysfunction, any cardiovascular disease, or severe hypertension has been excluded. There are also immunosuppressant drugs like cyclosporin, rituximab, or teprotumumab, which can be given in these patients. Orbital radiotherapy is usually just a second-line therapy when steroids are showing partial response. It shows a non-specific anti-inflammatory effect, and it also leads to modulation of soft tissue inflammatory changes because the lymphocytes are highly radiosensitive. So it can be administered alone or with concurrent oral or intravenous steroids. It has adverse eye effects like it leads to dry eye, cataract, worsening of the retinopathy, optic neuropathy, and long-term secondary tumors. It can also lead to transient exacerbation of the inflammatory eye signs and symptoms, which can be treated with steroids. Diabetic or hypertensive retinopathy is a contraindication as it can lead to bleeding or worsening of the retinopathy. Inactive disease is treated in the following order. First, we can do orbital decompression, then squint surgery, and then eyelid surgery. Orbital decompression can be done by bone removal or by fat removal. In bone removal, we have 3 approaches. We have an orbital approach, transcentral approach, or transnasal approach. The transnasal approach is preferred in patients with compressive optic neuropathy, for which optic canal decompression is also needed. In fat removal, we typically go through an inferotemporal transconjunctival approach, and from there the fat is excised. approximately 3.5 to 6 mm of proptosis is reduced. We can also have a combined approach to the lateral orbital wall where bony decompression and the orbital fat decompression can be done simultaneously. Squint surgery is indicated only after the angle has been stable for at least 6 months and the disease has been inactive. We can use adjustable sutures or we can use normal sutures, and mainly the inferior rectus is involved, and a recession surgery is the one which is mostly done in these patients. Eyelid surgery is basically done for retraction, a lengthening or weakening procedure on the LPS Muller's complex. So there are 4 main surgeries which are done. One is a Muller's muscle excision, one is a levator myotomy, one is an LPS recession with or without spacer, and one is a transverse blepharotomy. The first image in which we can see the eyelid lengthening procedure in which the Muller's muscle is being excised. The second is the levator myotomy, and the third incision of a spacer graft between the LPS and the tarsus. There is also a treatment of botulinum toxin available when there is any contraindication for the surgery, or if the patient is just having a mild disease and is concerned about the retraction. And a single transcutaneous injection is given at the central superior tarsal border, aiming at the LPS and Muller muscle complex. And the dose is about 5 to 6 units, and it has a temporary effect. The treatment, however, has side effects. It can lead to ptosis, it can lead to vertical diplopia, there can be ecchymosis, or there can be an ocular surface discomfort in these patients. Lastly, we have the sight-threatening graves of ophthalmopathy. 2 main components are there: compressive optic neuropathy or an exposure keratopathy. These warrant immediate intervention. In this thyroid optic neuropathy, as we have discussed before, we can have an optic disc edema along with peripapillary hemorrhages. We treat with very high dose of intravenous steroids. 1 gram is given for 3 consecutive days or on alternate days. If this does not work, we can go for an orbital decompression, especially if there is a recent onset of choroidal folds or an eyeball luxation. After 2 weeks, once the disease has settled, we can go for pulses of weekly therapy, as has been described in the management of moderate to severe and active Graves' orbitopathy. Lastly, we have severe exposure keratopathy, as we can see in this image. In these patients, we treat with tarsorrhaphy with topical lubricants, intravenous methylprednisolone, as well as orbital decompression. Other measures fail. Thank you.
Yes, I think we can take up questions now. For the residents, this is a very important topic because it comes as a long case. And even clinically, when you will come across cases of thyroid eye disease in your clinics and OPDs. And like Asmita showed in her presentation, most of them would be mild. But this is a common entity, and it is a very important question, very important case for your exam. So she's comprehensively covered everything in her presentation. I hope all of you had gone through her the document that she circulated, because otherwise it would be too much of information to be able to capture in the minds just in the presentation. So that will be a good guide. She's covered. So Abhijit has asked, just a minute, there is one question here. Let me just see. Okay. So Abhijit has a question. He's asking, ma'am, proptosis management is not that satisfactory in TED. Okay, Asmita, would you want to say something?
Ma'am, I'm not really sure what he means by it is not satisfactory, because we can go for immunosuppression and we have like orbital wall decompression with each wall, like moving from the medial, lateral, with every wall we can have more decompression, and even fat decompression can be combined with it. So I'm not very sure what he means by it is not satisfactory.
That's true. It's a little vague question. Mostly when you're talking about proptosis correction, I believe you're talking about the quiescent phase of disease, by which time the inflammation has already. I think a lot of mics are on. Can we, Gaurav? Can we have your mic muted? Yes. Mute your mic. Yes. Okay. So. Gaurav, I think your mic is on. Anyway, so proptosis, like we were talking about, is usually treated in the quiescent phase once the inflammation has subsided and there are no more signs of inflammation for at least a year or so. Severe proptosis is difficult to treat because, like Asmita said, we have the option of decompressing the orbit with 4 walls. So often now fat is considered to be the first wall. So you could do a fat decompression if you only want to correct around 2 millimeters of ptosis. Another 2 millimeters could be treated by a lateral wall decompression. So you can just keep adding the walls. So if you want a 4 millimeter decompression, you could do a lateral wall decompression along with the fat debulking. Another 2 millimeters can be added on by the medial wall decompression. And then, of course, you have the inferomedial decompression into the maxillary sinus. So roughly around 8 millimeters of proptosis is correctable surgically, but anything more than that is obviously difficult to correct surgically. So we have the option of correcting 6 to 8 millimeters. It also depends if the expansion of fat is more in a particular quadrant, because the fat decompression is mostly easier to do from the inferior compartment and not so much from the superior compartment again. So you have to see which wall you want to decompress, whether you want to do a fat decompression, depending upon what is the axis of proptosis. It is axial, but sometimes there can also be a displacement if the fat enlargement is not symmetric. So I would agree to a certain extent that yes, ptosis greater than 8 millimeter or proptosis greater than 8 millimeter would be a little difficult to treat in cases of thyroid eye disease. Let's see what other questions you have. Let's just check. Yeah, what are indications for imaging in TED? Yes, Asmita? Vishal is asking, what are the indications for imaging in TED? So in a diagnosed case of thyroid eye disease, when do you want to do an imaging? All right.
Ma'am,
Okay.
only I can think of when we are suspecting that if there is any risk of optic neuropathy, then we can look for apical crowding. That would be one indication for imaging in a case of thyroid eye disease, to look for any risk of optic neuropathy. That is one I can think of.
Yes, actually, when you're doing workup for a case of thyroid eye disease, you do get a baseline imaging if the patient has TED. So if you have a case of TED, you would essentially want to do an imaging first to confirm, because your ultrasound and your CT would confirm your diagnosis with the characteristic muscle thickening that you see in TED. Also, you would want to know what kind of TED the patient is having, whether it is because of the muscle hypertrophy or is it because of the fat hypertrophy. Yes. And again, as you follow up the patient, depending on how severe or rapidly the proptosis is increasing, you would want imaging maybe every 6 months or a year, depending on how rapidly it's taking the course. And sometimes, even in cases of mild proptosis, you may have a significant apical crowding. You don't have much proptosis, and essentially, if it is the case has only muscle hypertrophy and not that much of fat hypertrophy, then those cases are actually maybe at a greater risk of dysthyroid optic neuropathy, despite having only mild proptosis. So you definitely want to do it once, and on on follow-ups, depending on how rapidly the TD activity is changing or the severity is changing. So that should answer your question. All right. Then Anuja wants to know the current role of selenium in management of mild TED. When do we start the patient on selenium? Okay. So Asmita?
Ma'am, I feel it just has an additive role. I read some papers. They are mentioning that in mild disease it can be given as 100 microgram, but the benefit was not very substantial. So we can give, but ma'am, I didn't see any substantial benefit of giving selenium in a case of thyroid eye disease.
Yeah, actually, the studies that have been done by the UGOGO group, they have found that the population, most of the population in Europe and the ones that have developed PED have a selenium
Yes,
deficiency.
ma'am.
They have, like Asmita is saying, there are no studies which clearly show how effective it is, though they have found that it does delay the worsening of TED if you start selenium early when the patient is still having mild TED. So, therefore, according to the UGOGO guidelines, selenium should be started as soon as a TED is diagnosed. So, if I would say if selenium were to be started as per the UGOGO guidelines, yes, in all cases of mild TED, one has to start the patient on selenium. Ananya Goswami is asking, ma'am, which wall decompression is usually preferred as first line, medial, or lateral? Again, Ananya, decompression, the choice will depend on how much do you want to decompress. So if you have only a 2 to 4 millimeters of proptosis, then you could just go ahead with the lateral wall decompression, which is actually the safest way of decompressing. And it is most commonly done by the oculoplastic surgeons. The medial wall decompression is more commonly done by the ENT surgeons. So if you say for me, if I had to do one wall decompression, I would prefer to do a lateral wall decompression than a medial wall. But then that, along with the fat decompression, can only correct around 2 to 4 millimeters of proptosis. So if I have to correct more than that, then I would have to choose a second wall. And in order to balance the effect of lateral decompression, I would want to do a medial decompression along with the lateral decompression for, say, about 6 millimeters of decompression. So, however, the medial and the inferior wall decompression have a higher risk of diplopia because you are opening the orbit into the sinuses. Essentially, you are creating a defect in the wall, the medial wall and the inferior wall, and you're allowing the fat to prolapse into the sinuses. And sometimes your muscle could also get, impacted into the sinus, which could result into a squint. So that's why. So if I let me see, if in 2 to 4 millimeters of ptosis, one would go for a lateral wall decompression. Up to 4 to 6, you would want to do a lateral wall plus medial wall, and anything more than that, you will have to do all the 3 wall decompressions. Otherwise, the proptosis, residual proptosis, will remain. Sumant Sharma has asked, is there any role of orbital biopsy in TED, especially in euthyroid and unilateral cases? So again, Sumant, TED can present as unilateral proptosis. In fact, it is the most common cause of both unilateral and bilateral proptosis in the adulthood. Okay, so we do often get cases who have typical imaging findings of TED, but they are only unilateral, and the patient is euthyroid. What we do in such cases is first to follow up the patient and to see if, his lab tests show any dysfunctions in the thyroid status. The other thing that you could do is to get the TSH receptor antibodies test done. So if you find those antibodies, you know that this is a case of TD, only it is not showing chemical manifestations yet, but the antibodies are still there. But sometimes even the antibodies are negative, and in such cases, we generally assume it to be TED. And see, again, biopsy from muscle can be quite traumatic for the muscle. So usually we follow up the patient, and if you see any rapid increase in the one of the muscles that would be suggestive of some neoplastic etiology, we usually do not go ahead for an orbital biopsy. We usually keep the patient on observation. And in case, there are some signs that would suggest development of a neoplastic etiology, then in those cases, we go ahead with a biopsy, but not in the routine. Okay. Are there any more questions? I don't see any other messages here.
No, ma'am. No, ma'am. There are no more messages, ma'am.
Okay. I think, yeah. So please go through the whole presentation that she circulated to you, because it's nicely covered. Read about all the classifications, which are very important. Again, the order of the surgical correction in the quiescent phase, which is very, the question that examiners are very fond of very often. And of course, you must also read about rituximab, which is a newer drug that is now used in TD management quite often in cases where there is a optic nerve compression. So that is something new that has come up. But other than that, I think Asmita has covered everything very well, and you just need to go through it again and yeah, remember all the signs.
Yes. Thank you.
So thank you, Dr. Rachna, and thank you, Asmita. And my only this thing is, Abhijit, we have to find a solution to this. The attendance dwindles and